West, really the incidence of gallbladder cancer and access to cholecystectomies have gone parallel with each other. So as the use of cholecystectomy increases, gallbladder cancer in the West is a disappearing disease. We see very few patients now. So the same will happen in India, as we find their patients are being diagnosed early, have access to safe surgery.
In the prevalent areas like Gangetic Belt, where we see predominance of these cancers, one, the biology is aggressive and we have a predisposition, but also there is systemic delay. I would say that a lot of times these people are having the chronic infection, inflammation, gallstones, which remain undetected, untreated. The referral pathways are really fragmented, and all does also contribute to what we are seeing here, much more aggressive way and staged up.
Do you think individuals with chronic gallstone in high incident regions should be counseled differently?
Definitely, India is divided into an urban area, especially Delhi, Mumbai, Bangalore, and especially the rural areas, which is Gangetic Belt, the eastern part of India. There is limited access to the investigation, the diagnostics. When we talk about the 7 sisters, in 7 or 8 states, we have hardly 1 or 2 PET scan machines. We have limited access, especially in the high incidence areas. That is actually causing significant diagnostic delays.
We have esteemed speaker Dr. Milind Javle, who is a professor of gastrointestinal medical oncology at the University of Texas MD Anderson Cancer Center. We have Dr. Jyoti Bajpai with us, who is a professor and the lead medical and precision oncology at Apollo Hospitals, Navi Mumbai. We have Dr. Darshit Shah, who is a consultant medical oncologist at Sir H.N. Reliance Foundation Hospital.
So it is estimated by 2040 that liver cancer, including cholangiocarcinoma and HCC, will be among the top 5 causes of cancer death, whereas right now it's much lower. So we're going to see the relatively rapid increase in our country, unfortunately, unless we do something about it. And I think those in charge of education and the power structure that exists have to realize that we can only improve the health of our patients if we invest substantially in our own faculty and our own students to participate in this type of research, because they will find the answers that are relevant in India, and they will find the solutions that come from our people rather than from elsewhere.
Does the financial toxicity prevent people from participation, taking further treatment, or is it also the fear and mistrust to take up the treatment?
Financial toxicity does play a major role, where the acceptance of immunotherapy is only 4 to 5% in India. All know that for the first line for gallbladder and cholangio is adding immunotherapy to chemotherapy. Out of 100 patients, if the data shows that only 5% of patients are able to afford immunotherapy, that's a minuscule number. People have limited insurances, there is always a capping. The penetration of insurance is not that great in rural India and tier 2 tier 3 cities. So that is major limitation in India.
I think awareness is the key. I would say that, please be aware about things. Do not neglect any untoward symptom for long. Reach out to medical help and right medical help also, I would like to say. Many times we are seeing this fragmented referral pattern also. So if you're not getting resolved, then please see somewhere higher so that, we can detect in time. And when we are detecting in time, there is a lot to offer. So the era is really, changing. Present with the biomarkers which we identify, at least in 10 to 20% cases, we can really apply precision oncology knowledge and we can really treat them well. So definitely the future is brighter than what it used to be before.
Hi everyone, I am Priyanka, founder of Zarurat Care Foundation. We are a patient advocacy group focused on GI cancers in India. In today's podcast, in collaboration with Servier Pharma and Voice of Healthcare, we understand the rising burden of GI cancers in India. India carries one of the highest burdens of gallbladder cancer and cholangiocarcinoma globally. Are we witnessing a true biological difference, or are we facing systemic blind spots in prevention and early detection? Today's discussion explores incidence, patterns, diagnostic gaps, and everything. We have esteemed speaker Dr. Milind Javle, who is a professor of gastrointestinal medical oncology at the University of Texas MD Anderson Cancer Center. Dr. Javle leads the biliary tract cancer program and is internationally recognized as a leading authority in cholangiocarcinoma. His pioneering work is biomarker-driven therapies, FGFR and IDH1 targeted therapies, and global clinical trials has significantly influenced modern treatment strategies for hepatobiliary malignancies. We have Dr. Jyoti Bajpai with us, who is a professor and the lead of medical and precision oncology at Apollo Hospitals, Navi Mumbai. With over 20 years of experience predominantly as a professor at Tata Memorial Hospital, she specializes in treating all common, rare, complex, advanced malignancies through precision medicine, medicine, immunotherapy, and personalized care. An internationally recognized expert, she has contributed to global clinical practice guidelines with Society for Immunotherapy of Cancer, European Society for Medical Oncology. She is also the founder and president-elect of Immuno-Oncology Society of India and a leader in advancing equitable, high-quality cancer care. We have Dr. Darshit Shah, who is a consultant medical oncologist at Sir H.N. Reliance Foundation Hospital. He has been formerly associated with Tata Memorial Hospital, Mumbai, one of the leading cancer centers in India. At Tata Memorial, he was actively involved in managing complex high-volume GI malignancies within a multidisciplinary framework. Dr. Shah has a focused interest in molecular oncology, biomarker-driven therapies, real-world integration of next-generation sequencing in Indian oncology practice. We welcome you all to the podcast today. Starting over with the first question I have for Dr. Javle. India reports disproportionately high numbers of gallbladder cancer and cholangiocarcinoma. From global research perspective, does this reflect true biological difference or under-recognition elsewhere?
So you're absolutely right, Priyanka. Gallbladder cancer, we have probably the highest burden in the world by numbers. The actual incidence is probably higher in Chile, but the prevalence is probably, in terms of numbers, India leads, unfortunately. So I think a lot of that is biology. There is an ethnic predisposition, particularly in the northern part of the country, and not just in India. I see patients in MD Anderson from adjoining Pakistan, Afghanistan, Iran, Bangladesh. So there seems to be something about the north and east where the populations have a predisposition to develop this cancer. There's a very strong correlation with gallstones, and unfortunately that chronic inflammation seems to lead to cancer. In terms of cholangiocarcinoma, I don't know that we have the highest incidence. It's more so in the Far East, in Thailand and China. But certainly it's a growing problem in our country. And I believe this is something to do with lifestyle issues.
Got it. My next question is to Dr. Jyoti. Do Indian patients present with distinct molecular profile or more aggressive tumor biology compared to the Western patients?
So I think, Priyanka, very important question. And I would like to say that, what was said before also, and we are discussing about that there is chronic IDH1 mutation or FGFR. They are generally more or less similar. That's what is being reported. I want to really put one important fact is that, especially in the prevalent areas like Gangetic Belt, where we see predominance of these cancers, there is, the biology is aggressive and we have a predisposition, but also there is systemic delay. I would say that a lot of times these people are having the chronic infection, inflammation, gallstones, which remain undetected, untreated. The referral pathways are really fragmented, and all that also contribute to what we are seeing here, much more aggressive way and staged up.
Got it. When we are talking about the risk factors, my next question is for Dr. Darshit. If we had to identify one dominant driver in India, chronic inflammation, infections, environmental toxins, or metabolic syndrome, which deserves deeper scientific focus?
So, Priyanka, I personally feel it's predominantly, as Dr. Jyoti commented, is chronic inflammation, because of gallstones, especially in gangetic belt, and they are quite ignored since a long time. They don't reach the doctors on time, and there's significant delay. Apart from this, there is definitely a rise in obesity, which actually also is one of the very important risk factor, metabolic syndrome. Also, infections contribute. So, all of the factors contribute, but predominantly I would label it as chronic inflammation and metabolic syndrome.
Understood. When we are talking about, the diagnostic delays, Dr. Jyoti, do you think that, the diagnostic delays are caused because they are biologically silent or because referral pathways and awareness is fragmented in India?
So I think, again, we need to really put much attention on this particular question, because I think both factor plays an important role. In early phase, there is, biological silence also, because the symptoms are really subtle and, non-specific, and as we move. But later, I think much more importantly, especially in our, part of the world, it becomes the systemic delay, which is much more important, and people are chronically hepatitis B virus infected, and they are not doing any kind of screening. They are even disregarding the symptoms, the chronic dyspepsia, other things. The people are having gallstones, big gallstones. They are having off and on the episodes of pain, but people keep on ignoring it. Partly the responsible factors are awareness, partly also, and rather predominant, I would say, financial and logistic reasons also, which are very, very important. So I think there has to be a systemic approach also to deal with it. We need to create an awareness. We need to educate our primary healthcare personnel because they need to understand that they should not be neglecting this dyspepsia symptom by just giving some symptomatic medications, and rather they need an early referral. So referral pathway fragmentation is very important part of losing them early in the care, and rather we are still receiving them in our tertiary care centers at very late stage.
Got it. So, Dr. Darshit, do you think that the primary care physicians in India should receive more structured training on early red flag signs of GI malignancies because they get diagnosed in a very late stage?
Definitely, I completely agree. The referral system needs to be improvised upon. The diagnostic delays which are usually happening should be, minimized. Weight loss, jaundice, and loss of appetite. They are kind of common symptoms which are ignored for a long period of time. And as we have seen that in tertiary care hospitals, the patients are presenting in a very advanced stage. And gallbladder carcinoma or cholangiocarcinoma itself is a very aggressive disease with very little survival. So if they are diagnosed early, the survival definitely improves dramatically.
When we are talking about the early screening, I think ultrasound imaging is one of the very non-invasive way which we can use. My next question to you, Dr. Javle, is that are we overusing advanced imaging in low-risk individuals while underutilizing it in high-risk populations?
But I think it's a difficult question to answer, Priyanka, because I think we just have inadequate imaging per se overall in early stages of the disease. So when patients have symptoms, like Dr. Bajpai and Dr. Shah said, they should have access to laboratory testing, to ultrasound, and safe cholecystectomy to be done early, for instance. I think in the West, really the incidence of gallbladder cancer and access to cholecystectomies have gone parallel with each other. So as use of cholecystectomy increases, gallbladder cancer in the West is a disappearing disease. We see very few patients now. So the same will happen in India as we find their patients are being diagnosed early, have access to safe surgery, and identify which of the patients actually require cholecystectomy. In terms of advanced disease, I think we have very good imaging in India. I think they're used appropriately. I don't want to comment on types of imaging because circumstances can vary, but I think that access is available as long as patients meet the criteria for proper imaging.
So I just want to add to what Dr. Javle really said it very well, that at times we also feel that there's disproportionate things, in urban people, there may be an over diagnostic, tests which are being done, while in the people who are having symptomatic since really while in rural belt or especially in the high prevalence areas, they are not imaged when they are really required. So I think that factor also we need to really taken into account.
Right. My next question to Dr. Darshit is, like, when we are talking about the risk stratification, do you think individuals with chronic gallstone in high incident regions should be counseled differently?
Definitely. So, India is actually divided into an urban area, especially Delhi, Mumbai, Bangalore, and especially the rural areas, which is Gangetic Belt, the eastern part of India. There is limited access to the investigation, the diagnostics. When we talk about the Seven Sisters, I hardly remember in 7 or 8 states, we have hardly 1 or 2 PET scan machines. We have limited access, especially in the high incidence areas. That is actually causing significant diagnostic delays.
That makes sense. I think there is more and more, government intervention needed when it comes to having more screening programs in India. My next question to Dr. Javle is that with fatty liver disease rising rapidly in urban India, are we underestimating the future HCC burden linked to metabolic syndrome?
Yeah, I definitely think so. I think Darshit said it very eloquently before. So India has the second highest number of patients with weight challenges in the world. Also, I think among the top 2 diabetes type 2 in the world. So this is unfortunately a situation where steatosis is fairly common with high BMI as well as with diabetes. So it is estimated by 2040 that liver cancer, including cholangiocarcinoma and HCC, will be among the top 5 causes of cancer death, whereas right now it's much lower. So we're going to see a very high, the relatively rapid increase in our country, unfortunately, unless we do something about it.
Dr. Jyoti, if India were to implement a cost-effective screening model for liver cancer, what would be realistic and more scalable, which can go to from urban to rural population?
So I think very important, and as the prediction says that by 2040 we will be seeing a very high incidence, and which is worrisome and really alarming. We need to implement certain program at national level, which will be really effective and doable. Something if we will suggest very fancy, probably it will not be able to do in every place. I think a simple ultrasound based screening, especially if the patients who are having a high chances of developing these diseases, like if they are having a chronic hepatitis B virus, or if they are having a gallstone disease. These are the most important and kind of a low-hanging fruit where we can really start doing a screening. In screening and other populations should also be done, but probably we should be kind of triaging that which patient needs more rigorous screening and which should be a priority.
So I'd like to add to something which Dr. Bajpai mentioned. So, most of the patients we see with advanced cholangiocarcinoma in our practice have actually had some abnormal liver enzymes in the past, which were never followed up with. So the tools are relatively simple: annual checkups, blood tests for liver enzymes. There is a special kind of ultrasound called FibroScan, which is really quite cheap, not that expensive. That can be used as a screening tool for patients at high risk. And that can lead to further investigation. I think the biggest the tool we have, though, beyond all this, is just awareness. That people are aware that this could happen, so that they self-advocate one of these testings.
I think very well said, and exactly the awareness and this is simple measures. Also in cirrhotic patient, or for example, the people who are having this fatty liver disease, maybe we can even check for alpha beta proteins periodically. That is also non-invasive, and perhaps we can pick them fast. So all these measures may be very effective.
I mean, as we know that NGS has completely changed the treatment game globally for, these stage 4 malignancies in GI cancer. How much do you think it can change in India? Because, access to NGS is still very, very limited in India to people. Only 10-20% patients can afford it. And even when it comes to getting the therapies which are entailing from the NGS. So how do you think, this can be beneficial for the patient, and how we can scale it up further in India?
So I think, Indians by nature, we are very innovative people. We can make do with very little.
Yeah.
I remember, PCR used to cost like $90, $100. Now it costs like pennies to $1. So these tests are available in India at far cheaper rates than they're available in the West. The quality of those tests continue to improve. And I think we need more and more sequencing. We really do not know the genetic alterations in the Indian population because not that many patients have been sequenced. So we need to do more and more of this. There have been nice papers, including one from Darshit's group, one from Moshbi Suryavansh's group, some landscape of what is the genomic alterations in biliary cancer and other cancers. We need more and more of those.
Dr. Jyoti, in your practice, do you suggest, your patients to undergo NGS immediately when they are diagnosed with cholangiocarcinoma or gallbladder cancer? Or is it typically when the first line of therapy fails? So how is the judgment made?
So I think, in advanced cases, my preference would be to do upfront. And many of the markers, they are, early phase markers. So if you find them early, it's better. And as such, we also know that these are kind of really fatal disease. And later on, almost a third of the patient, they go to second line. So I would prefer to do upfront. Although right now, the guidelines suggest that, even in cholangio, we have to start with the conventional therapy. But if they fail, later we can use the biomarker driven therapy, but later lines the tissue also become an issue. It is always an issue, but even more in later lines. So I prefer to do it upfront if that is feasible. And I completely echo what Dr. Milind said, that we really need to sequence our people to know that what is the difference. There might be some pharmacogenomic variations also. We have seen in a couple of other diseases the drugs, they behave differently. In our own studies from Tata Memorial, I find that everolimus for breast cancer, very simple drug, that our dose was different than what is the Western, correspondent. And similarly, Jeftinib story everybody knows, and even the Pazopanib in sarcoma, we found that our dose is 1/3. So we definitely need to know what is peculiar about our our own genomes.
When it comes to, having, because as a patient advocate also, we want to advocate to have NGS done upfront for every patient. So I want to understand from the experts in India, you and Dr. Darshit, that, how can we make it as a standard guideline so that, every patient can get their upfront NGS done the moment their diagnosis is confirmed via biopsy?
So I think awareness again, and also the cost effective options, that is very important. Insurance is not covering these tests at present majority of the time, so that is also one of the challenge. So how can we convince the people that this is important one?
Right.
And also, if it is really really cost challenging, then perhaps we can try it also those patients, because we know that the chances of intrahepatic cholangio are having highest mutations, so at least that part must be taken care. And similarly in GI tract, if we see colon is another malignancy wherein we see the maximum difference NGS can make. So if we really need to try it, then we can go that path. If it is possible for every patient, then definitely it is better.
So you did mention that around 10 to 20% patients have access to NGS. So now I would say the numbers are improving. The cost of NGS also is coming down substantially. The panels which actually were costing maybe 1.5 lakhs are now coming down to a significant lower number. We are also doing limited gene panels. So our goal is, at least in Mumbai and wherever in TMH where we are practicing, the patients should get an NGS done, because we in gallbladders and cholangios we have limited lines. So if we are able to find something like IDH1 or any other mutation which actually we can target, so they should not be deprived of the therapy.
Right. So my next question is to, you both are experts in immunotherapy. We've also wanted to shed some light on another hepatobiliary tumor, which is pancreatic cancer. It's a silent killer and often very resistant to chemotherapy, and there are very limited treatment options. So what do you think, is the future for any pancreatic cancer patient in terms of treatment?
So yeah, I think you very rightly said that it is kind of a immune cold tumor, and there are multifactorial things for that. There is a dense stroma. There is immune activated cells are less, and that those are the challenges. Even the microsatellite instability, which is one of the marker, is also found very less. Tumor mutational burden is less. So all these factors put together make this kind of tumors immune cold. There is only 1% chance that they will come as MSI high, which is one of the very important marker. But again, those 1% we don't know upfront, so we have to check them.
Right.
So that is one thing. And again, now we all are working towards that. How can we convert this immune cold tumor to immune hot? I think Dr. Javle's group is also doing a lot of work on those things. So I think we need to really learn to tame the beast, and what permutation combination are best. In the immune cold tumor, perhaps the single agent would not work, but perhaps we can combine with chemotherapy and other things, so that we can propose them, or we can present more antigens to them, so that
Right.
we can convert. So that would be perhaps one of the suggestions.
So I just want to add that, of course, Dr. Bajpai said it very well. These are very immune-depleted tumors, pancreas. But I think among the most exciting things I've seen in my lifetime for pancreas cancer is the KRAS inhibitors. KRAS gene is mutated in over 90% of pancreas cancer, more like 95%. And that was a hard mutation to target. Just the nature of the molecule required to target TERA. It was just not easy to do. That code has been cracked. And now we have some very exciting drugs from all over the world, from US, from China, hopefully soon in India. And I think that is a real opportunity now, isn't it? As compared to what we ever had before.
Yes, absolutely.
That's wonderful. And just for our viewers, KRAS is one of the most aggressive mutation. And, if at all it comes up, your tumor is more aggressive than any other genetically altered tumor. My follow-up question to this is that I have been, looking up certain resources where, some pharmas have developed a drug which turns a cold tumor into a hot tumor, so that it's more, responsive to any kind of immunotherapy. What is your take on that, and what is the future of it?
So there's certainly that, as you said. Now, I think to expand on what Dr. Bajpai said, there's some tumors which are very immune depleted. They have hardly any T cells at all. And there's some tumors that are immune excluded, where you have T cells, but they can't reach the tumor because of fibrosis and scarring and so on. The latter group, where they're immune excluded, you can rescue them sometimes with checkpoint inhibitors. But even with drugs that are now approved in India, like IDH1 inhibitor, ivosidenib, we have found that inhibiting that mutation with a specific inhibitor can make the tumor more immunogenic. More T cells are seen in the tumor. So this is now being investigated as a strategy. And I think we see that in other tumors as well, right, Darshit? In gastric cancer, for instance.
Yes, sir.
Dr. Darshit, people have a lot of misconception with regards to cancer treatment in India. They just think that it's chemotherapy. So with the emerging, precision oncology setup across the globe, what do you think is the biggest misconception amongst Indian patients with regards to precision oncology?
We are now in this era, 2026, we are actually moving away from chemotherapy. When we talk about lung cancer, hardly we are using chemotherapy. We are, moving more and more towards targeted therapies, towards immunotherapies, and different options. The same applies to different cancers like gallbladder also, cholangio also. But definitely chemotherapy remains an essential backbone in terms of cholangio for cholangios. But precision oncology involves identifying specific mutations. We are able to target them. Side effect profile is also very favorable for the patients, and the survival and the outcomes are significantly better. So this is basically the precision oncology. It's a living. We identify specific mutations and we target them.
Right. I think my next question is to everyone over here. Precision oncology, of course, requires a tumor biopsy to be done. And with our work with a lot of patients, we have also seen a lot of patients, their tumor is located at a very difficult site to be extracted from. So in that scenario, do they lose out any kind of options of treatment, or, how further we are advancing with regards to the biopsy in India?
So I think a very, very crucial question, especially for these cholangio, etc., because tissue is an issue for every tumor, but for these even more.
Yeah.
So I think where this is not practical or not possible, liquid biopsies has come in a bigger way. Even now the techniques are more advanced and they are able to even target the other body fluids like pleural fluid, like bile even they are trying to see a concordance and moving. So liquid biopsy is a reality for sure. We can, take advantage of that. So that is one thing. Another, I just want to add what was said by Darshit very nicely about the precision thing. So I want to tell that many times people perceived it very differently and kind of a fancy thing. I would like to say that what once upon a time a fancy is a reality today.
Right.
And precision oncology doesn't really connote that it is very expensive thing only. Precision, when I say, we have to be very cognizant while we are choosing things, whether we are choosing diagnostics or therapeutics. So precision not only involves doing all the sequencing, it also involves when we offer an age-specific care. For example, a geriatric patient
Right.
more than 65 is very differently treated than adolescent and young adult, which is less than 40, with different kind of challenges. And similarly, even gender medicine. So woman, male, these are differences. And then also their cultural practices, their professional commitment, their other challenges. When we actually take cognizance of each factor, that is precision medicine or intelligent delivery to me. And again, economics is also a science. So we take cognizance of that as well. Because for me or my team, person sitting across to me is most important and every factor dominates there. So precision oncology is not only expensive treatment that I want to say, rather it is intelligently planned and intelligently delivered treatment. Perhaps chances when we are using these biomarker driven tumors, biomarker driven care is that we can get more efficacy and less toxicity is higher.
That's right. Do you see it any differently in Western countries, Dr. Javle? The biopsy issues which people come up with, some people have reported they have the tumor in the spine or something like that. It's very hard to locate.
No, I think we face the same issues. I mean, patients fear that the cancer may spread,
Right.
if you get a biopsy. Those fears are not completely unfounded, but if it's done in a proper way, it's done in a large institution with experience, really the risk is very low. And like Dr. Bajpai mentioned, some biliary cancer, for instance, perihilar cholangiocarcinoma, they shouldn't be biopsy. This is just too small an area. Risk of seeding is high. And then you can use liquid biopsies. I think the arena for liquid biopsies is going to expand more and more in the future. And we are going to get information from the blood primarily.
Got it. Dr. Javle, I was going through one of your talk in which you had mentioned that, for any person to undergo a liver transplant, the standard Mayo Clinic practice is that the person should not have undergone any biopsy. So if a person has a localized tumor, liver cancer tumor, how would they get an NGS done, and, how would they still be compliant with the transplant setup?
So that particular protocol, Priyanka, is for perihilar cholangios. And in that case, you really don't have much tissue to biopsy anyway, because it's like the tumor is in the bile duct. There's no big mass that you can put a needle in. So we get cytology. So it's not a big issue for that tumor, and you can get a liquid biopsy. The data for needle biopsy and contraindication for transplant is based on a very small number of patients, I want to add. So, but I think the bottom line is that you can get that information without a biopsy, with a blood biopsy.
Got it. Okay. Now we want to touch base a little bit about, clinical trials, which has been the growing trend, and it is like a life-saving thing for any patient across the globe. My question to Dr. Jyoti is India under-enrolling eligible GI cancer patients in clinical trials, and what are the core barriers?
So I think extremely important and vital question. And yes, I would say that it is very embarrassing. But yes, this is true that in spite of having a very high prevalence, we are not enrolling them in enough numbers, right? Rather 5%, in some institutions 10%. Those kind of numbers we are enrolling. And this is the need of the hour. We really need collaboration. We really need collaboration internationally, nationally to build our own data and to speak the one language, and that will enhance our understanding and open up many pathways. I would like to congratulate Dr. Javle's group. The biomarker driven care, precision oncology based treatment and clinical trials what were conducted at MD Anderson under his leadership. And we can collaborate with a couple of those efforts here. And certainly India, also I would like to perceive that there should be a different trial needs to be conceptualized here and also enrolled all over. It should not be other way around all the time, that we are kind of a recruitment side. It should be like India has enough talent and enough capabilities that we should be perceived as thought leaders, and we can take that forward.
Right. Dr. Darshit, with your recent practice with Tata Memorial, as we all know, Tata Memorial experiences very high volumes of patient, and of course, most of the patients come with financial burden. So I want you to shed some light on financial toxicity. Does the financial toxicity prevent people from participation, taking further treatment, or is it also the fear and mistrust to take up the treatment?
So very important question, Priyanka. Financial toxicity does play a major role. I mean, we all know that we had a ESMO presentation in the TMH group, and my colleague did presented in ESCO, where the acceptance of immunotherapy is only 4 to 5% in India, and we all know that for the first line for gallbladder and cholangio is adding immunotherapy to chemotherapy. So out of 100 patients, if the data shows that only 5% of patients are able to afford immunotherapy,
Right.
that's a significantly, a minuscule number. So also we have limited, people have limited insurances. There is always a capping. The penetration of insurance is not that great in rural India and the tier 2 or tier 3 cities. So that is a major limitation in India. But we do have a significant amount of push from the government. The current government is pushing very hard to open new centers, and in all the yojanas which government is adding up, they are trying to cover much more as compared to previous.
Understood. Dr. Jyoti, what do you think, the kind of structural reforms which is needed in India to have more of tier 2, tier 3 patients be enrolled in more trials? Because, they often are the ones who come up with financial burden, and, if they get any kind of trial enrollment, that will be very, very good for them to, continue forward with the treatment. So how can we, get more patients enrolled from tier 2, tier 3 cities?
So I think very important question again, and I would say that there has to be a hub and spoke model. When I was in Tata Memorial or All India Institute, we were seeing that there are a couple of trials. There are many multi-institutional, multinational trials which were there, but patients who are coming from far off, like they are coming from remote Bihar, UP, they're not able to stay, even though the drug cost is nil because it is under trial. But logistics, staying in Mumbai is not easy.
Agreed.
So those all are, kind of hidden cost, which
Mhm.
which implicate a lot. So I think there is a need that we need to open many satellite centers,
Mhm.
and because they require hand holding, so the people who are experienced and who are having those kind of kind of capabilities, they need to handhold. And even pandemic made us really wise. There can be a lot of telecommunication, other things, so that they can run the trial in the similar manner what we are doing here. But there has to be this is a need of the hour, that there is many centers which should be open. We don't have any deficiency of patients. We need those logistics and infrastructure challenges. So that is extremely important in
Yeah.
our opinion.
And I think more awareness about the clinical trials as well, because, a lot of patients still don't know what clinical trials are. They come up with questions like, there is something called placebo, and they think that they're not going to receive any drug. But they don't know it's going to be chemo versus, a different drug which they are trying. But yeah, I think our audiences, our entire Indian population needs to be encouraged about clinical trials, let know about, awareness side. Yeah.
So very important. I think this message must be loud and clear,
Yeah.
because many times we are struggling to convince them to get enrolled in trials. Rather, in Western world, almost every patient follow one trial. So many times these myths are prevalent, and they feel that they are being used as a guinea pig, and they don't want to take part in the
Exactly.
trial. Some patients, even educated class, I find it very difficult to convince them. They just will trial, meaning some experiment is going on,
Right.
and which will not help me.
Yeah.
So that is not true. Many of the path breaking research were kind of for the fruit of those kind of trials only. We know imatinib story, isn't it, which has changed the epidemiology of chronic myeloid leukemia. So I think they needs to understand it better, and also discuss with right people, because many times the well wishers or the people who are providing suggestions are not having enough knowledge.
Understood. So my last two questions are going to be very open-ended, because we are going to discuss more about, international collaboration. So as we know, Dr. Javle, India has the highest incident rates of GI cancer. Still, all the experiments, everything that is being done, majority of the translational oncology is being driven in Western countries, where the Indian population is very underrepresented. So how do you think, we can have more collaborations in terms of, getting the tumor samples from India, or maybe, we can have more of such research done within India? So what is your take on that?
So honestly, I think the India has the talent. We have some of the best chemists in the world. Our pharma industry is improving, and they are developing new drugs. I think the trials we need to do in India have to be India-centric. We don't have to follow the Western model. And some very innovative research has been coming out from India. Low-dose nivolumab,
Yeah.
Which showing much cheaper, most effective cervical cancer vaccine, the actual number of doses, metronomic chemotherapy. So I think these are sort of questions that we will look forward to coming from India. But I think overall, we need to have some investment in infrastructure. The cost of trials in India is so much cheaper than what we do in the US. So if we establish a good infrastructure, we establish good centers that are enrolling patients, and we can, really India-centric trials led by Indian investigators, I think is a need of the hour. And I think that's what's going to drive the science in India, not necessarily from the US, where we hardly see any gallbladder cancer at all.
Right. Dr. Jyoti, I mean, in your practice at Tata and also at Apollo, how much difficult or easy has international collaboration been for you, making some experimental drug, or, driving any kind of research that is happening in a Western country in your own center in India?
So I think there are challenges and opportunities both. It was, as I mentioned, in Tata Memorial, because we had a big research team, and the intent, it was a university hospital. So we were doing a lot of research, and many trials which has provided access to our patients, and a lot of good data which is generated. Also, Dr. Javle, as he mentioned, our problem, our solutions.
Yeah.
So I would like to mention that from Immuno-Oncology Society of India, we conceptualized, because the immunotherapy drugs, they were pretty expensive. And right now, with the generic availability there, the cost is being decreased. But again, Previously, it was, probably the 5%, 10% orbit. So we did a short course, like we collaborated from 13 centers in the country under our society umbrella. We have shown that only an abbreviated course of 5 cycles is kind of equivalent to the standard course, although there are certain limitations for those kind of researches, but still something is better than nothing. So those kind of things, innovative things needs to be done here. I see a big challenge that we are doing a lot of trials. Even in Apollo, I enhanced the trial unit, and we are having now a couple of good pharma trials, but majority of them are phase 3. What I see a need is that we have to do early drug phase trials. So a lot of patients who are coming in recurrent advanced settings, they are lost with options, and not everybody can travel abroad. So this is the need of our, and we need to collaborate on that.
So I think collaboration, Jyoti, has always been with US and EU. I would hope we can see more collaboration with China.
Yes.
China has made huge leaps in pharma industry. The government invested really majorly. And even in the 20 years ago, where hardly anything was coming out of China, a lot of the new drugs for oncology are coming from there. So I would like to see more bridges being developed between our countries, and so that we can develop trials. You're already using a lot of the drugs from there, right?
Absolutely.
Immunotherapy and so on. So I do hope we can have collaborative trials and some at the leadership level, find a bridge that helps our patients that is beyond politics.
Yeah, so very well said. I said beyond geographical boundaries, beyond any taboos, what we are existing. Ultimately, we are working towards humanity and patient care. So really, we need to make such bridges. Completely with you.
Definitely. Dr. Darshit, I've seen in your practice, you've been working very closely with other TMH centers as well, like Varanasi and other ones, Given these places are like tier 2 cities, how much of like a global collaboration do you see over here? Because again, these institutes also come with a very high incidence of GI cancer, especially coming from the northeastern belt. So
Definitely. So, Varanasi, specifically when we talk about in last decade, the number of patients which are being treated in TMH Varanasi has grown exponentially. The geographical location actually, drains entire Uttar Pradesh, the Bihar, and parts of Madhya Pradesh. Especially the northeast also. It's a predominant Gangetic belt. So when we talk about the incidence and the number of loads of gallbladder cases, the cholangios, they are huge number. The thing which is lacking is definitely international collaboration, the infrastructure, the support from the government is there, but it's still lacking. So we need to improvise upon that. And it is, the numbers in TMH are actually lesser, I would say, as compared to the TMH Varanasi when we talk about the gallbladder cancers.
got it. Again, a very open-ended question for everyone. Beyond the clinical trials, what structural reform do we need in India, where the investment should be made in the next 10 years so that there can be like a global partnership in translational research, data sharing, and academic exchange. So it's a very open-ended question. Please, give your thoughts on that, how we can encourage more of that.
So Priyanka, I think I learned in this trip because I went to the Gujarat Cancer Research Institute. I went to Nagpur, the National Cancer Institute, and also in Kochi, Amrita Center, Visakhapatnam. So I found really young people who are enthusiastic, bright, really want to change the current paradigm as it exists. And I feel like we don't have enough investment in research. So when I look at their training program, what they are doing, there's very little time allotted to research, learning methods of research, trying to change the trajectory of education in such a way that they learn how to conduct trials, what are the questions, how to bridge a gap between clinical and laboratory work. That's what I learned when I did my fellowship in America. You have one whole year devoted to research. It doesn't have to be that long, but it has to have a significant commitment. And I think those in charge of education and the power structure that exists have to realize that we can only improve the health of our patients if we invest substantially in our own faculty and our own students to participate in this type of research, because they will find the answers that are relevant in India. And they will find the solutions that come from our people rather than from elsewhere.
Dr. Jyoti, do you have anything to add to this? How we can, do you think that in India, while you are doing any kind of academic, in your practice, you should have dedicated academic hours for any kind of research to be driven, and that will make some difference in bringing more of, these kind of drug discovery related work in India.
Absolutely. I think it is so much needed. And I was just discussing, before also that in India, this is a major problem that even in the university hospital, we do not get a protracted time for research. Even at a very senior level of consultancy also, it's like all 6 days you are in the OPDs and you are doing all sorts of works, and then you burn your personal time, which is also very little if you have fire in the belly, and then you conduct those kind of research. So I think if there is some dedicated time, especially the people who are really, really keen to do such things, it will be, several folds, I would say increment in what is being done here. We can really reach to next level, because many times what I'm feeling that, actual understanding what he was mentioning in your training periods is not even developed, because people are trying to finish things, tick mark.
Right.
And many times they are perceiving it as one of the things, so just I have to write one paper on this without even really getting the soul of it, that why we are doing, why we are asking this question, right? Because the guide said, the thesis guide said, so I have done this, but I really don't not interested, but I want to finish it to crack my exam or something. Very blunt truth, but many times I feel this is what is happening. We need to 360-degree make a change through this, and we really need to make these people kind of, there should be an appetite, there should be a curiosity, which I want to see in the young leaders. They are the budding oncologists, and that's how we can really change the spectrum, and then we can collaborate at every level.
I mean, as we speak of young leader, Dr. Darshit is a very young leader with us over here. And Dr. Darshit, with your experience as a professor at Tata Memorial, would you have appreciated if you were given some dedicated academic research time, and would that have compromised with the patient care you guys were providing? Because I can see that there is such a high volume of patient coming every day, close to like 200 patients being seen in the OPD.
So definitely, still I would say in TMH I had that opportunity, and I would say, I was lucky enough that I did from TMH that we did search. We had written papers, we have published papers, and but still there is a lot of things we can improve upon, because it's a high volume center. We have to simultaneously focus on patient care, we have to do night duties, and we have to also focus on the research part. But as Javle sir mentioned that, we need to have a structured program where the students get sufficient time to do research and, publish.
Papers.
Yeah.
Got it. I think this pretty much covers, the entire understanding a user needs to have for gallbladder cancer and cholangiocarcinoma landscape in India. And we are truly thankful, Dr. Javle, Dr. Jyoti, and Dr. Darshit, for your precious time to come together and, have a one-on-one discussion with us. If you would like to add anything further which our audience should know about, this malignancy, please feel free to have your, input over here.
I think awareness is the key. I would say that, please be aware about things. Do not neglect any untoward symptom for long. Reach out to medical help, and also take right kind of medical help. I also want to urge to community practitioners that do not neglect any symptom which looks subtle, like chronic dyspepsia or some pains, gallbladder stone, etc., and refer well in time, because if we can detect well in time, there is definitely more to offer with much better means. Also, I want to say, it is not the previously it was very nihilistic, but at present with the biomarkers which we identified, at least in 10 to 20% cases, we can really apply precision oncology knowledge, and we can really treat them well. So the future and present is brighter than what it used to be before. So one should be optimistic and try to reach well in time. Also, I want to say that we need national and international collaboration. We need sister institutions wherein our youngsters, our leaders should go exchange knowledge, even exchange of tissues, etc., where we can do this biomarker driven care and research and find more and more solutions.
Anything you would like to add, Dr. Javed, Dr. Darshit, for our viewers?
So I think screening is that key. Early diagnosis is very essential. Do not ignore warning signs, and please reach out to your doctor in case of prolonged symptoms.
So I would say, just to add to what they say, I'm just amazed how much people in India use their phones and use their social media. Pretty much everyone. So this is a good opportunity to build a community, to connect to an organization like Priyanka has developed with Zarurat Care, and really build a village so that you can talk to each other and learn from each other.
Definitely, we will build a good community and we will be, at the out front in India. With this, we end our podcast. Thank you so much.